Acute ischemic stroke occurs due to sudden intracranial vessel occlusion, leading to abrupt reduction in cerebral blood flow. Critical perfusion thresholds determine tissue fate, with complete cell death occurring within 4 to 10 minutes at zero flow. Infarction occurs when flow falls below 16 to 18 milliliters per 100 grams per minute within 1 hour. The ischemic penumbra is salvageable tissue surrounding the infarct core and is the main target of reperfusion therapy. Cellular injury involves ATP depletion, ion pump failure, calcium influx, glutamate excidotoxicity, and reactive oxygen species damage. Risk factors worsening injury include fever and hyperglycemia above 200 milligrams per deciliter or 1 millimoles per liter. Transient ischemic attack is defined by neurological symptoms that resolve before infarction occurs. Stroke management begins pre-hospital with stroke code activation and rapid transport to a stroke center. Immediate evaluation includes airway, breathing, circulation assessment, and bedside glucose correction. Non-contrast CT brain is performed urgently to rule out intracranial hemorrhage. If onset is within 4 or 5 hours and no hemorrhage is present, intravenous thrombolysis is considered. Alteplase dose is 0.9 milligrams per kilogram, with 10% as bolus and remainder over 60 minutes. Tenecteplase can be used as a single bolus at 0.25 milligrams per kilogram up to 25 milligrams. Contraindications include uncontrolled hypertension, bleeding diathesis, recent surgery, or active hemorrhage. Endovascular thrombectomy is indicated for large vessel occlusion in internal carotid, middle cerebral, or basilar arteries. Thrombectomy benefit is highest when groin puncture occurs within 2 hours and may extend up to 24 hours with favorable imaging. Blood pressure is lowered if above 220 over 120 millimeters of mercury, or above 185 over 110 before thrombolysis. Aspirin is started within 24 to 48 hours for non-thrombolized patients to reduce recurrence risk. Dual antiplatelet therapy with aspirin and clopidogrel is used short-term in minor stroke or transient ischemic attack. Cardioembolic stroke requires anticoagulation with direct oral anticoagulants or warfarin depending on valve status. Carotid stenosis may require endarterectomy or stenting, especially when symptomatic and greater than 70%. Intracranial atherosclerosis is managed medically, as trials show stenting increases risk compared to aggressive medical therapy. Cerebral edema peaks between 2 to 3 days and may require mannitol, hypertonic saline, or decompressive hemocraniectomy. Deep vein thrombosis prevention includes early mobilization and prophylactic heparin when appropriate. Stroke unit care with early physiotherapy, occupational therapy, and speech therapy improves outcomes and survival. Etiology includes cardioembolism, large artery atherosclerosis, small vessel disease, and less commonly hypercoagulable or vasculitic states. Cardioembolic stroke typically presents with sudden maximal deficit and is often due to atrial fibrillation. Workup includes ECG, echocardiography, vascular imaging, lipid profile, and glucose evaluation. Secondary prevention focuses on blood pressure control below 130 over 80, statin therapy, smoking cessation, and antithrombotic selection. Clinical takeaway: rapid imaging, timely reperfusion, and targeted secondary prevention determine survival and neurological outcome in ischemic stroke.